Hi, my name is Will Mary Rodriguez. This is my Module 7 Adult Health 2 didactic assignment with Aspen University. So, for this assignment, we were asked to select two musculoskeletal problems. And the two that I decided to choose and talk about would be osteomyelitis and amputation. So, to begin, osteomyelitis is a severe infection of the bone. It can also interact with the bone marrow and the surrounding soft tissues. The pathogen that we find most common to cause osteomyelitis would be Staphylococcus aureus. Pathogens can be introduced to the body via indirect or direct entry. The most common one would be direct entry. It does account for about 80% of all cases of osteomyelitis. We see this most typically in adults. It doesn't really affect pediatric patients as much. Now, it can be a result of an open wound, such as like a cut or something like that. Pathogens will, make the best out of that situation and enter the body as much as they can. It can also be as a result of an implant, a prosthetic, anything like that that's being introduced into the body. It always has that risk of, having bacteria on it and then introducing that into the body cavity, which is something we don't want. Typically, in direct entry, we find more than one microorganism is typically involved. On the other hand, we have indirect entry, which is not as common, and it does account for only 20% of osteomyelitis cases. We find that this is more common in pediatric patients. It does also affect older patients, and risk factors for older patients with indirect entry would be old age, patients undergoing hemodialysis, debilitation, IV use, and even sickle cell disease. We typically see indirect entry most commonly in the vertebrae, and we only see one microorganism typically associated with indirect entry. The pathophysiology behind osteomyelitis would be that once microorganisms enter the blood, they can begin to multiply and proliferate. As the number of microorganisms increase, so does the pressure. And now, since bones are very rigid and they're not very flexible, that pressure can decrease blood flow or lead to ischemia. It could also compromise the vascular system that supplies the periosteum, which is the outside of the bone. The infection can eventually spread through the bone cortex and down to the bone marrow. This can interrupt the blood flow, and it could even eventually lead to necrosis or death of the bone. Once that portion of the bone dies, it will begin to separate itself from the healthy part of the bone, and that will form what is known as sequestra. Now, uh, part of the periosteum that still has an active blood supply will begin to form its own new bone, and that's called the involucrum. Now, since the dead part of the bone that started to separate itself, called the sequestra, uh, it doesn't have easy access for white blood cells and antibiotics to reach it. So that can easily become a breeding ground for bacteria, and that can eventually also like travel to other parts of the body, such as the lungs or the brain, and that can cause a serious issue that we do not want to deal with because it could lead to other life-threatening issues. How to diagnose osteomyelitis? There's two definitive ways to diagnose what kind of bacteria is causing osteomyelitis, and that could be through a bone or a soft tissue biopsy. X-rays can diagnose osteomyelitis, but it doesn't pick up on osteomyelitis until about 2 or 4 weeks after the patient starts exhibiting clinical symptoms. So that means that once the X-ray does finally pick it up and sees that yes, this patient does have osteomyelitis, it means that they've had osteomyelitis for 2 to 4 weeks, and so it's not new; it's progressed. A CT scan can also diagnose osteomyelitis, and it's actually considered more effective. Clinical manifestations of osteomyelitis will include ongoing bone pain, and that doesn't get better with rest and actually worsens with activity. You might find some swelling, some tenderness, warmth at the site of infection, and even an inability to move the affected part. Systematic symptoms of osteomyelitis will include night sweats, fever, restlessness, chills, malaise, and even nausea. Interprofessional care. So, cultures or a bone biopsy may be done prior to the patient receiving surgery or even starting antibiotic drug therapy. Typically, antibiotic drug therapy starts in the hospital and it will continue for about 4 to 6 weeks after. On certain occasions, it can take about 3 to 6 months for the entire course of antibiotics to be ran. Because that is a considered long term antibiotic therapy, the patient will most likely have a CVAD place or even a PIC line to help distribute that antibiotic and make it a little bit safer for the patient. Surgery may be consulted to remove any poorly perfused tissue or necrotic bone. Wound care will also be consulted, as would nutrition. Orthopedics when may be consulted for a fitting of a prosthetic device if amputation is on the table. As well, physical therapy and occupational therapy would be consulted as well. Now, when we see osteomyelitis, we typically see amputations or even just surgery to help get rid of the dead bone that we don't want because that could, like we said, lead to further infection and could even lead to sepsis, and that's bad in and of itself. So once surgery is done, they'll typically be put on IV antibiotics, such as penicillinase resistant penicillin, ampicillin, or even cephalosporin. We might even see daptomycin, commonly used for osteomyelitis. A nursing diagnosis for a patient experiencing osteomyelitis would include ineffective tissue perfusion related to swelling of the blood vessels. And you can see that due to the edema. The edema is a swelling, so you'll notice that. Two outcomes that we would want to see in a patient with osteomyelitis would be that the patient would be able to demonstrate improved perfusion. And we would see that through a decrease in their pain, a decrease in erythema or redness, and even swelling. Swelling should go down. Another outcome would be that the patient would be able to remain free from infection, fever, abscesses, all the good stuff throughout their stay on the unit. Interventions that we can implement include provide DVT or deep vein thrombosis prophylaxis, such as heparin, to circulate the blood a little bit better. That helps promote circulation and it prevents the formation of new blood clots. We also want to educate the patient on managing chronic conditions and lifestyle factors, which lead to more negative results, and we don't want that. How can we evaluate that our patient is that the interventions that we set in place are good and that the outcomes that we're expecting are coming to life? We would have the patient teach back what has been educated to them to ensure that the patient fully understands the instructions provided. We also want to assess the patient daily throughout their stay on the floor to ensure that they haven't developed any DVTs, any fever, infections, abscesses. Patient teaching for osteomyelitis would be teaching the patient of taking their medication as directed, especially antibiotics. We want to remind them to not stop taking their antibiotics even if they start feeling better. We definitely don't want them to start developing antibiotic resistance. We want to teach a patient to be careful with their where their infection is at. We don't want to injure that. That would just make the situation worse, and it could even lead to a possible amputation if amputation wasn't already in the picture. We want to tell the patient to follow all discharge instructions as closely as possible. And if they are a smoker, we want to teach them the importance of smoking cessation. Smoking has a lot of bad, negative uh, influences on our health, and it definitely has a bad influence on osteomyelitis. Moving on to amputation. So amputation is just the removal of a bodily extremity. It can be done either through trauma or surgery. So typically, in older patients, we'll see that amputation could be a direct result of PVD or peripheral vein disease. In younger people, we see that amputation is unfortunately due to trauma. But other reasons could include like thermal injuries, tumors, osteomyelitis, congenital limb disorders. The list goes on and on. How can we diagnose amputation? You can't really diagnose amputation because it's a procedure, but we typically do diagnostic uh, testing on why. Why are we amputating? So, let's say they have an infection. We're going to run a complete blood count with differential, which will show if there's an active infection somewhere within the body. If, let's say, that we're amputating because of circulation issues, we'll do vascular tests such as arteriography, Doppler studies, and even venography. Clinical manifestations, once again, varies depending on why the amputation is being performed. Interprofessional care, if the amputation is elective, we want to perform a complete and thorough assessment on the patient. The goal of surgery is always to preserve the most length possible of the extremity, while also getting rid of all of the necrotic and dead bone. Because we don't want, like we said, we don't want to leave that bone in there to then cause an infection, get into the blood, sepsis, all that good stuff. We don't want that. Treatment plan and medication. We definitely want to refer the patient to see physical and occupational therapy, a physiatrist, a psychologist, even case management would be useful in a situation like this. After surgery, we would want to put the patient on antibiotics and even providing them a prescription for a prosthesis. Nursing diagnoses for a patient with an amputation typically will see impaired physical mobility, and this is related to the loss of a limb. They've just lost, one of their balance. They lost the majority of their balance. So we're going to see a lot of um, impaired physical mobility. Outcomes that we would see is that the patient will be able to verbalize understanding of the treatment plan and safety measures that are set in place by the healthcare staff by the end of the teaching session. We'll also want the patient to display willingness to participate in activities within 3 days. So interventions that we can implement, patient education, why the treatment plan is important and how they should adhere to it. We want to encourage the patient to perform exercises. This could help prevent stump trauma. We could also teach a patient of maintaining a knee extension and even provide trochanter rolls as clinically indicated. Evaluation, how can we evaluate that our teaching is going well? We want to have the patient uh, teach back in their own words why their treatment plan is the way it is and why it is important to follow the treatment plan. We also want the patient to be able to and once again, in their own words, tell us how exercises are beneficial. And we actually want to see the patient engage in these exercises as well. Lastly, patient education. We want the patient to be able to inspect their stump on a daily basis. And this is important because infection is very high. And so we want the patient to be aware. We want them to look for any redness, which is erythema, swelling, a warmth, anything like that that could be a sign of infection so that it can be caught early on. If they have a prosthesis and it's causing irritation, we want them to know that they should stop using their prosthesis as soon as possible and get it checked out because prosthesis shouldn't really be irritating them. We want them to wash their limb every night. I know that goes without saying, but sometimes you do have to say it. We want to, get rid of any bacteria that could proliferate and invade, and that would be, washed out with good soap and water. We want to remind them don't use any lotions, powders, alcohols, or oil on the residual limb. Perform range of motions. Don't elevate the limb, and only wear a residual limb sock that is in good condition and prescribed by the doctor. You want to change. They want to be changed out daily to ensure optimum efficacy. And that concludes my Module 7 presentation. Thank you.